We very recently saw data presented by Dr. Mateos on behalf of her investigators in a randomized phase 3 trial of MPV, melphalan, prednisone, and bortezomib, versus MPV plus MPV plus DARA. And I think that trial is called the Alcyone trial, recently published in the New England Journal, and led to the FDA approval of MPV plus DARA for newly diagnosed myeloma in a transplant-ineligible patient population. I think this is a hint of more to come. We're going to see data combining Lendex with DARA. We're going to see emerging data on RVD plus DARA in randomized trials as well. And I think this gives us insight into the idea that DARA clearly is able to add value both to bortezomib and to MPV. I think the real question for us in the U.S. is that MPV is not a regimen that we routinely use. And we will even rarely use bortezomib and Dex for newly diagnosed frail patients. And so I think how do you extrapolate that data to our everyday patients in the U.S. remains a little bit of an issue. I'm not sure that I'm not incorporating DARA into every newly diagnosed myeloma patient at this time point, but I think if you have patients that perhaps are very frail, thinking about DARA-based combinations might be a gentle way to try and get them a deeper response. I think another important area to look at is data evolving Lendex or Cardex as a backbone on which to add DARA in the context of newly diagnosed myeloma. Again, we know from the first trial that Lendex is clearly a great and well-tolerated treatment for these patients. Can you make it even better with the addition of daratumumab, given the IMiD antibody interaction? The Maya trial will give us that data, DARA-Lendex versus Lendex in a randomized phase 3 trial. I think the readout is taking a long time, which is a good sign, meaning that the PFS is quite good for the DARA-containing arm. I think trying to use another backbone, such as carfilzomib, sort of recreating a Castor-like trial with carfilzomib instead of bortezomib in a newly diagnosed myeloma setting is also really exciting. We have to see data on some of that before we know how to use it. One question that comes up quite frequently is, if we use an antibody as powerful and potent as DARA up front, what are you going to use down the road? And the way I think about that is DARA as part of these induction regimens will likely be short duration DARA, and in my mind for a lot of patients they'll go on to transplant, and then we'll have a discussion about whether DARA gets put in the maintenance setting. Those trials are being done right now looking at DARA in the maintenance setting. So I think short duration DARA exposure in the context of a newly diagnosed patient doesn't necessarily preclude the use of DARA at a later date. There also is emerging data from trials looking at DARA retreatment, and I think having a DARA-free interval helps to use DARA again down the road, so that would be a potential option. And there are other antibodies that we can talk about using, whether they're antibody-drug conjugates or whether it's elotuzumab, which targets something completely different that we could think about in the relapse setting as well.